Welcome to the Head to Toe Assessment brought to you by Dr. Catherine Prado-Lefkowitz and Nurse Muse. I know students have some difficulties with the head to toe assessment, but I'm going to teach you how to do it in a stepwise manner and how you should articulate and then be able to document your findings because students are great at performing the head to toe assessment. They're not always sure on how to articulate their findings, and you need to understand how to articulate your findings because then that's your normal baseline, because you probably practice this in lab. So that's your normal baseline. And then from there, when you understand exactly what you're testing for as you move throughout your program, you'll gain more skills, more tools in your toolbox to really identify what is expected versus unexpected. So let's get started. It's really important as you work to becoming a nurse to have your systems in place. So you do the assessments the same way each and every day so that you don't forget a step, you don't forget a body system. So if you go from head to toe, you should not miss anything on the patient's body. So you need to be consistent, and you should always first inspect, second palpate, third percuss, and fourth auscultate, except for the abdomen. We'll talk about that when we get there. So be consistent, go from head to toe on every single patient so you do not forget a body system. Step one when performing a head to toe assessment. First and foremost, you're always going to clean your hands, hand hygiene. Then you're going to always provide privacy. Introduce yourself to the patient, your role, and then you're going to explain to the patient what you are going to do. You're going to look at the armband to assess you have the correct patient, and you can also ask them their date of birth, and that we always try to at least do 2 patient identifiers to make sure we're doing what we're supposed to be doing on that individualized patient. You can start out by just having a normal conversation. How are you doing today? How are you feeling? Because this is part of the assessment too. Are they able to answer your questions? Are they have any problems speaking? Do they understand what you're asking? Are they hard of hearing? Things like that. But we also need to get an alert orientation status. So we need to know if he knows who he is. So state your name. We already did that when we were doing the 2 patient identifiers. Where he is, what he's doing there, and any current events that are happening, because we want to make sure he's oriented. It's usually the person, time, place, and situation, but there are many ways you can just, through a normal, casual conversation, gather this data. Next, you're going to do the vital signs: blood pressure, heart rate, temperature, respiratory rate, oxygen saturation, and pain level. We always ask our patients if they are in pain. We're going to collect the height and weight if that's appropriate for the patient. If they're bedbound, we're not going to have them stand up. We're going to be looking at the BMI. 18.5 or less is underweight, and 30 and above is obese. So you're already collecting information. You're looking at the patient's emotions. Do they look their stated age? What is their skin color? Does it match their ethnicity? They're answering your questions appropriately. They're responding appropriately. You can see just by looking at somebody if they have any outward abnormalities. Do they have any amputations? Are they sweaty? Are they cyanotic? Is their hygiene appropriate for the time and place of what's going on? Is their posture appropriate? And you can just get a good general overview at this point, the beginning of the assessment, to notice any of these things. And again, you could just talk to the patient throughout the assessment, just making sure that they are speaking clearly, that they know who they are, where they are, what's on. You can talk about current events to make sure that they're up to date with current events, or if they can remember current events. So there's a ton of stuff you can gather just by first walking into the room. So we are starting at the head and we're going all the way down to the toes. So this is the sequence that I use, and I think it's a great sequence because, again, you won't forget a body system. So after we've gone through step one, we're moving on to the head. We're just going to focus on the head. We're just going to look at the patient, and we're going to look at the skin on the face. What is the color? So you're going to document or articulate skin color is appropriate for ethnicity, no twitching of the face is symmetrical, no drooping. So that's just an overview of what you're seeing right now. Next, you're going to put on gloves and you're going to palpate the cranium. You are going to assess for masses, infestations, lesions, open areas. And you would document or articulate no masses, infestations, lesions, or open areas on the cranium. I also want you to part the hair in different parts of the head and look for infestations. So you can state no infestations noted. If the patient has a beard or a mustache, you must assess that hair and underneath that hair as well for the same things we just talked about. We want to assess the hair to make sure the hair is evenly distributed. So you would document hair is evenly distributed, so there are no bald spots that you can see. You're going to feel the hair texture. You're going to document hair texture is fine and clean. Then we're going to move down to the eyebrows. We want to look to make sure the eyebrows are symmetrical. Hair is evenly distributed bilaterally. So you can just do, this is just a visual inspection, so that's what you would document and or say. Eyebrows are symmetrical bilaterally. Hair is evenly distributed. Next, go to the ears. We want to assess the ears to ensure that they are symmetrical bilaterally. You're going to look for any drainage. You're going to use your pen light. You're going to look for any drainage coming out of the ear. You're going to ask the patient about any pain in the ear. Look for any skin breakdown. And we're going to be, like I said, using our pen light to look around the ears, inside the ears, and make sure you look behind the ears because people can have skin breakdown there as well. So it's important to look all around the ears, even behind them. You're going to document and or say, ears are symmetrical bilaterally, no drainage, redness, or skin breakdown. Now, since we're at the ears, we have to incorporate our cranial nerve assessments. So we are going to assess cranial nerve 8. So what you are going to do is stand 1 foot behind the patient. Have the patient occlude the right ear and whisper a word in the left ear and have the patient repeat the word. Then you're going to do the opposite side and have the patient occlude the ear you just tested, and hopefully the patient can tell you what the word was that you said. So you're going to say or document vestibulocochlear nerve intact, able to distinguish words whispered. Vestibulocochlear nerve, because that's what cranial nerve is called, is intact, able to distinguish words whispered. Continuing with the head, now we're moving down to the eyes. We're going to assess that the eyes are symmetrical bilaterally. You're going to look at the eyelashes. Are they evenly distributed? The hair. Assess for any crusting around the eyes, any drainage, open areas, redness, watering. Inspect the eyelid and the sclera. That part should be white. you're going to assess that the pupils are round, and you're going to assess the conjunctiva. So the conjunctiva is the pink part in the bottom of the eye. So what you're going to do is pull down on the bottom lids for your patient. You're going to have them look up, and the conjunctiva should be pink. You're going to ask about any concerns with their eyes, and this is also a great time to see when their last eye checkup was. So what you would say and or document: eyes are symmetrical bilaterally, eyelashes are evenly distributed bilaterally, no crustiness, watering, irritation noted, sclera is white, pupils are round, conjunctiva is pink, no swelling, and patient denies any concerns with his eyes. So we have just assessed the exterior eye, and now we need to assess the cranial nerves associated with the eyes. So what you need to know is that there's a condition called anisocoria, and this is when one pupil is smaller than the other. The pupil should be the same size in both eyes. Should be between 3 to 5 millimeters in measurement. And for the eyes, we can assess right now, because we're doing the eyes, cranial nerves 2, 3, 4, and 6. So cranial nerve 2 is called the optic nerve. And what you are going to have your patient do is have a handheld Snellen chart. The patient is going to cover one eye and read the lowest line he can out loud. Then he's going to switch eyes, and the patient is going to read the lowest line he can out loud. And then the patient is going to read the lowest line with both eyes open. And you're going to record the Snellen results, such as patient has 20/20 in right, left, and both eyes. Then we move on to cranial nerve 3, which is ocular motor nerve, and this is also referred to as PERLA. So we're going to look at the size and shape of the pupils. We are going to shine the light with our pen light into one eye, and the eye with the light in it should constrict. Then you're going to shine the light into the same eye, and you're going to be looking at the opposite pupil. Is it constricting as well? Because it should be. Next, you're going to hold the pen light about a foot away from the patient's eyes and shine the light into the eyes. The reflection of light should be in the center of both pupils. That should be a positive light reflex. Finally, you're going to hold the pen light 6 inches from the patient's eyes. Tell the patient to look at the tip of the pen light, and you're going to slowly move the pen light in toward the eyes, and the eyes should converge, which means they should come both together toward the nose, and the pupils should constrict. Cranial nerve 4 and cranial nerve 6, you do the same test, but you're assessing different muscles. So cranial nerve 4 is the trochlear nerve. You're going to have the patient look at the tip of your pen light. You're going to stand about 1 or 2 feet away from your pen light, and you're going to move the tip of the pen light in the 6 cardinal fields of gaze, and make sure that the patient only follows the pen light with his eyes, not his head. So you will slowly move the pen light up, down, side to side, and then diagonally, starting from one side of the body and moving it upward to the opposite side of the body, and you're going to do this on both sides. And this innervates the superior oblique muscle. So make sure you have 6 gazes, 6 cardinal gazes. So that's up, right, left, right, up, down, left, right, and then the diagonal on both sides. Now the cranial nerve 6 is the abducens nerve. And again, you're going to have the patient look at the tip of your pen light and move the pen light in the 6 cardinal fields of gaze. You only have to do this once, by the way. And make sure the patient only follows the pen light with his eyes and not his head. And we're going to do the 6 gazes. And this innervates the lateral rectus muscles. So you can do all of these assessments right when you're assessing the external eye. and how you would document and or state this. Cranial nerves 2, 3, 4, and 6 intact. Patient's vision is X in the right eye, X in the left eye, and X with both eyes. Pupils are equal, round, reactive to light and accommodation, also known as PERLA, P-E-R-R-L-A. Pupils are equal, round, reactive to light and accommodation. Patient's eyes move equal bilaterally and smoothly during the 6 cardinal gaze assessment. No nystagmus noted. Now we are moving down to the nose. So you're going to assess the nose for symmetry. Is it symmetrical on the face? With your pen light, you're going to inspect the nares for redness, drainage, swelling, and any open lesions. You can also ask the patient if they have been having any pain in their nostrils or on their nose. Hopefully the answer is no. And then we can also assess cranial nerve 1, which is your olfactory nerve. So what you're going to have the patient do is occlude one nostril and have the patient inhale a scent. You can use scents like vanilla or cinnamon and ask the patient to tell you what scent that is. Next, you're going to have the patient include the other nostril, get a different scent, and have the patient identify that scent correctly. So how you would document and or say this is nose is symmetrical, no drainage, swelling, redness, irritation noted, cranial nerve 1 is intact, patient is able to identify scents in each nostril. Moving down to the mouth, we are going to first assess the lips. Are they pink and moist? Hopefully your patient doesn't have dry, cracked lips. You're going to have the patient open his mouth, and with your pen light, you're going to look inside the mouth. The mucous membranes should be pink and moist. Gums should be pink. You're going to assess the tongue. It should be pink. You're going to have the patient lift his tongue so you can look underneath the tongue for any lesions or discoloration. And you're also going to be looking at the teeth and note any loose teeth. Since we're here, we can also assess cranial nerve 12. We're going to have the patient stick his tongue out. The tongue should protrude midline, and you're going to ask the patient to move the tongue from side to side. You're also going to assess for any halitosis or bad breath. And how you would document and or say this: lips are pink, mucous membranes are pink and moist, no lesions noted in the mouth or under the tongue, gums are pink and moist, teeth intact, no halitosis noted. Cranial nerve 12 is intact, tongue protrudes midline, and patient is able to move tongue side to side without difficulty. Now we're going to assess our temporal pulses. And I have a picture here so you can see where you would find the temporal pulse. What you're going to do is place 2 to 3 fingers on both hands over both temporal pulses at the same time, and you're going to rate the pulse. We use a rating scale of 0 to 4, and so you always need to rate the pulse in your documentation, either 0, 1 plus, 2 plus, 3 plus, or 4 plus. So 0 is no palpable pulse. 1 plus is faint, but a detectable pulse. 2 plus is slightly less diminished than expected. 3 plus is considered an expected finding. 4 plus is a bounding pulse. So how you would document and or describe this is by saying temporal pulse is 3 plus equal bilaterally. So now we're palpating down the face. So now we're going to move to the TMJ area on the face. and this is the temporomandibular joint. So you're going to place 2 to 3 fingers over the temporomandibular joint on each side of the face. You're going to ask the patient to open and close his mouth while you feel for any grinding, popping, or clicking of the TMJ, that joint right there. So what you would document and or say, TMJ assessment did not find grinding, popping, or clicking while patient opened and closed his mouth. So now we're moving down to the frontal and maxillary sinuses. So as you can see in the diagram below, you can see where the frontal and maxillary sinuses are located. For the frontal sinuses, you will place your thumbs over the frontal sinuses and add pressure. You will ask the patient if there is any pain associated with the pressure, and hopefully the answer is no. Next, for maxillary, you will place your thumbs on each side of the maxillary sinuses and add pressure. You will ask the patient if this elicits pain. Hopefully the answer is no. So how you will document and or say this is patient denies pain over maxillary and frontal sinuses. Next, we are moving down to the neck. So it's really important to think about when you're giving somebody a head to toe assessment that we don't want to have them moving from sitting to standing to laying down. So this is why our head to toe assessment has to be very systematic. And once we put the patient lying down, then they should lie down for the rest of the assessment until at the final end of it, we have them stand up. But we've gone from sitting to lying to standing, and it's in a sequence. So you're not having the patient sit, stand, lay down, because that can be very frustrating for the patient. So we're at the neck. And so first we're going to have the patient lie back at a 45-degree angle. And you're going to have the patient turn his head to the left and to the right. And what you're looking for is jugular venous distension, which is, I have a picture here on the right. And you can see how that jugular vein is popping out. And you might see it pulsating as well. So you're going to be looking for any JVD is what we call it, jugular venous distension, JVD. Then we're going to assess cranial nerve 11, and this is the spinal accessory nerve. So we're going to ask the patient to move his head from side to side and up and down, and you're going to put resistance on their shoulders and ask them to shrug, and they should be able to shrug against resistance. We talked about JVD. And now we have to palpate the trachea to make sure it is midline. So have the patient in a neutral position with his head, and you're going to feel down the trachea, make sure it is midline, and ask if there's any pain, tenderness, and you're going to feel for lumps as well. So how you would document and or say this is trachea is midline, no lesions or lumps assessed, no JVD noted, cranial nerve 11 is intact. Patient is able to move head side to side, up and down, and shrug his shoulders against resistance. Let's talk about lymph, because we're going to talk about lymph nodes and where you need to assess them on the face and neck. So number 1, lymph from the forehead and the anterior part of the face drains into the submandibular lymph nodes. The buccal lymph nodes may be present along the course of the previous vessel. Lymph vessels which drain the lateral part of the eyelids and lateral part of the face end in the parotid lymph nodes. The central part of the lower lip and skin of the shin are drained into the submental lymph nodes. So now we know where lymph drains. So we need to assess the patient's lymph nodes, which means we're going to use our 4 fingers on both sides of the face, and we're going to feel around where all of these blue dots are, because all of the blue dots represent a lymph node that we need to feel for. They have their own names, and you're going to have to, I've always said, I hate to say memorize, but you need to memorize the names of these lymph nodes. But everywhere there's a blue dot is where you're feeling for lymph nodes, and you're feeling for swelling, pain, or lumps. So of course, if the patient is complaining of pain in one lymph node, you need to document that, let the provider know. If you're feeling any lumps, you need to let the provider know so that he can order more tests. So you're going to feel all around the patient's face. You can just let the patient know, I'm just going to feel around your face. Let me know if you have any pain or tenderness, and you're feeling for any swelling, pain, or lumps or bumps. You have just assessed the lymph nodes in the head and neck, and now we need to know what you will document and or say out loud. You will say lymph nodes are free from pain, tenderness, lumps, or nodules upon palpation. Carotid arteries and bruits. I know it's spelled weird, but it's pronounced bruit or bruits. So what is a bruit? A bruit, also called a vascular murmur, is the abnormal sound generated by turbulent blood flow in an artery due to either an area of partial obstruction or a localized high rate of blood flowing through an unobstructed artery. The bruit may be auscultated by securely placing the head of the stethoscope over the skin, and you will hear a swishing sound. Note that most bruits only occur in systole, so the bruit might be intermittent. But you need to place the bell of the stethoscope over each carotid artery separately, and you need to listen for about a good 15-20 seconds, because like I said, these happen in systole, so we have to really maybe close our eyes and really try to listen for a bruit or no bruit. So if you find a bruit, of course you need to notify the physician, and the physician will usually educate the patient about quitting smoking, losing weight, eating healthy foods, reducing salt, and exercising. And because we're having damage with our arteries, it's usually caused by occlusion. So we have a lot of plaque building up in our arteries. The patient will most likely get medication to control the blood pressure and or lower the cholesterol in the body. And the provider may also recommend taking a daily aspirin or other blood thinning medications to prevent blood clots. So again, you're going to place the bell of the stethoscope over each carotid artery separately. If you hear a swishing sound, that is a bruit. So how would you document and or say this? No bruits noted. Before we discuss how to auscultate heart sounds, we need to learn the difference between the bell and the diaphragm on your stethoscope. The diaphragm is used for listening for high-pitched sounds such as S1 and S2 and the aortic and pulmonic murmurs. The bell, that's the smaller side on the stethoscope, is used for listening to low-pitched sounds such as S3 and S4 and mitral stenosis murmurs. How to position the patient the best way so you can truly understand and hear what you're listening for. Supine or sitting up. Here is a good way where you can use the diaphragm, the larger part of your stethoscope, and listen to all 5 auscultation sites. And here you can really hear S1 and S2. And also you can really distinguish S1 from S2. Then when you go all the way down to your 5 spots, you're going to stop at the mitral area with the diaphragm, and this is your great chance to listen to the heart rate at the mitral area for 60 seconds, noting rate and rhythm of that heart rate. Then you're going to flip your stethoscope over to the bell sounds, and you're going to go back up those 5 areas. And using the bell, you're going to be listening for S3, S4 murmurs. If the patient is able, the best position for him to be in to listen to S3 and S4 is on his left side. But if your patient is in pain or can't really move, it's fine. You can do it in the sitting or supine position. And you're going to have them sit up, lean forward, and have the patient exhale while you listen with the diaphragm at the aortic and pulmonic sites for murmurs. I keep referring to S3 and S4 sounds, so let's understand what they mean and how you can hear them. S3 is heard after S2, and it sounds like lub-dub-ta, 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 lub-dub-ta. This is caused by vibrations of ventricle filling from a resistant ventricle due to fluid volume overload or heart failure. S4 is heard before S1, and it sounds like ka-lub-dub, 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 ka-lub-dub. Heart murmurs, these are blowing or swishing noises from blood turbulence in the chambers of the heart, or a valve problem. So we do not want to hear S3 or S4, but if you hear an extra sound, lub-dub-ta, 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 is an S3, ta, lub-dub, ta, lub-dub, ta, lub-dub. That's an S4. Now, it's going to take you many years of experience to really start listening to the sounds and distinguishing the sounds. But if you hear anything other than lub-dub, 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 then you should refer that concern to the primary care physician. Grading murmurs. So we as nurses really don't grade murmurs, but you need to understand that we do grade them, and it would be excellent if you could describe on your documentation and your charting what the grade sounds like to you, just to help the other healthcare team members. So a grade 1 is hard to hear. So you think you hear an extra sound, but it's kind of hard, like unless you're really concentrating, you might not hear it. Grade 2 is faint, but heard. Grade 3 is easily to hear. Grade 4 is loud with a chest thrill. What's a thrill? You feel a thrill and you hear a bruit. So a thrill you can actually feel with your fingers over the chest wall, and you'll feel a vibration. Grade 5 is very loud. You can hear when the corner of the chest piece is lifted off the chest. And grade 6 is the loudest. You can hear when the whole chest piece is lifted off the chest. And by chest piece, they're talking about your stethoscope. So we've been talking about these 5 heart sound areas that you really need to take your time when auscultating. But first, before we ever touch our patient, we need to inspect the skin. Is it clean, warm, and dry? Any lesions, masses, any open areas? Ask the patient if he has ever had any pain in his chest or in his heart area or in his lungs. And we're going to assess the AP diameter. And note if he's using any accessory muscles or if you see any heaves or lifts. So inspect for heaves and lifts. Heaves and lifts you can see. They're actually, you'll see one part of the chest higher than the other. So the chest is not symmetrical bilaterally. And so heaves, these are forceful cardiac contractions that cause a slight to vigorous movement of the sternum and ribs. So remember, you feel a thrill and you hear a bruit. Thrills, you're actually going to palpate the chest and you're going to be feeling for any vibrations in your fingertips. You feel a thrill, you hear a bruit. And these vibrations, they're due to loud cardiac murmurs, and it feels like the throat of a purring cat. And thrills occur with turbulent blood flow. So we're going to palpate all cardiac sites, all these 5 sites. We're going to feel. We're going to ask the patient if he's ever had any pain in his chest or in his heart or in his lungs. And we're going to feel at the mitral area for the PMI. So here's a mnemonic to help you remember the 5 spots. But trust me, as when you do this 500 times, you're going to memorize them. It's going to just be on the top of your head. Okay, so all patients eventually take medications. So the first site is the aortic valve. And you most likely need to state this out loud when you're doing your head-to-toe assessment for pass-off. So, aortic, second intercostal space, right sternal border. And how do you find your intercostal spaces? You need to start from the top, under the clavicle, and then if you put your fingers maybe about an inch apart, you can start feeling the spaces in between the ribs. So aortic, second intercostal space, right sternal border. So here's a picture for you on the right. Pulmonic, second intercostal space, left sternal border. So as you're auscultating, you need to say this out loud for your pass-offs. It will be ingrained in your brain and it will actually help you so much in your career. Erb's point, third intercostal space, left sternal border. Tricuspid, fourth intercostal space, left sternal border. Mitral, fifth intercostal space, left sternal border. Now, when you get to the mitral area, as I mentioned before, this is a great time to listen to the apical heart rate for 1 full minute. You're going to be listening for rate and rhythm. How you would move forward from there, we're going to talk about in the next slide. So we are down listening to the apical heart rate for 1 minute. You're assessing rate and rhythm. And then you're going to take the stethoscope, flip it over to the bell, and you're going to, again, go all the way back up through those 5 areas. Here's another diagram for you to see where those 5 areas are. And while you're listening this time, you're listening for any S3 or S4 sounds that you did not hear with the diaphragm. So you go down with the diaphragm, you stop, you take the apical heart rate for 1 minute, noting rate and rhythm, and then you go back up with the bell, listening for S3, S4, those extra heart sounds. So how you would document and or say this: during auscultation of aortic, pulmonic, Erb's, tricuspid, and mitral valves with the bell and diaphragm, S1, S2 heard, no S3, S4. Apical heart rate was 60 beats per minute, regular rate and rhythm. So what's occurring with S1 and S2? During S1, the tricuspid and mitral valves are closing, and in S2, the aortic and pulmonic valves are closing. So if you take your two hands next to your body, put your hands so your palms are down, and then put your fingers together. That's lub. And then bring your hands up so your palms are facing your face, and put your fingers together. That's dub. So this is a good way to remember what you're listening for. So lub, the bottom ventricles are closing. Dub, the aortic and pulmonic valves are closing. So lub, dub, lub, dub, lub, dub. That is an expected cardiac sound, S1 and S2. Here's more information on what S3 is and how you can remember to learn how it would possibly sound. But again, you're just going to have to practice, 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 because your ear will start tuning in to finding more nuances when you start listening to more and more chests. But you can read this slide. Again, I'm just trying to give you as many tools as possible, so maybe one diagram or one piece of information might make more sense to you than another. So look at this slide. It tells you what's going on with S3 and what's going on in S4. During the lung assessment, you are going to be assessing for tactile fremitus. So what is tactile fremitus? It is a vibration perceptible on palpation or auscultation. What you're going to do, I'm going to teach you in the next slide, is you're going to assess the chest bilaterally at the same time with your two hands, and you're going to have the patient state 99, 99, 99 every time they feel your hands move. And what you want to feel is an equal vibration bilaterally in all the areas you're going to assess. So tactile fremitus is it's a vibration you're going to feel, and if it's loud, if you can feel it more on one side than the other, then that's not equal bilaterally. Because if you have a lot of secretions, then when you feel that site, the vibration is going to be much stronger, maybe in that one section of the lung you're assessing, but the other areas of the lungs have just a minimal vibration as the person speaks. We are now moving into the lung assessment. So there's a diagram here you can see, and it shows you where you're going to listen to the anterior lung sounds. But first, we need to assess the skin. Is it warm and dry? Any lesions, masses, lumps, any open areas? And you're going to palpate over all of these areas identified on the diagram. And you're going to palpate the lung fields for any pain, tenderness, lumps, or masses that you can feel. We also need to assess tactile fremitus, and it's also known as tactile vocal fremitus, and it refers to the vibration of the chest wall that results from sounds created by speech or other vocal sounds. Because when a person speaks, airflow from the lungs causes the vocal cords in the larynx to vibrate. So what you're going to do is you are going to, I have a slide coming up, but you're going to take the palms of your hands and you're going to do this at the same time on both sides. So because you want to assess right versus left, make sure that there is no tactile fremitus there. You should have tactile fremitus, but it should be equal bilaterally. So you're going to take the palms of your hands, place them above the clavicle on both sides, and then you're going to work your way down the chest, the mid-chest, and then underneath the breast area and around to the sides. So tell the patient every time you feel my hands on your chest, say 99. So you're going to start above the clavicle, 99, second intercostal space, right and left, 99, and all the way down, they're going to say 99. Then we are going to auscultate our breath sounds, And we're going to auscultate just where we did the tactile fremitus assessment. So you're going to go from a right to left pattern. I like to go right. I start with the right side above the clavicle. I move to the left side of the clavicle. Then I move down to the left second intercostal space, to the right second intercostal space, down to the third right intercostal space, then to the left. So I go in a pattern where I'm assessing each side and making sure that each side that I listen to is equal to the side I just listened to. So you're going to auscultate, and your patient is going to breathe normally. You don't want to have your patient hyperventilate, so have them just breathe normally. So this takes a little bit of time because you have to auscultate inspiration and expiration. So you're going to go down that similar pattern that you just did with tactile fremitus. Make sure you go under the breast and around to the lateral sides. You're listening for any crackles, rhonchi, wheezing, or stridor. And these are called adventitious sounds. Now, of course, we're going to talk about the posterior, but do not forget that you need to listen to the lung sounds anteriorly and posteriorly. Sometimes students forget to do the back. So how you would document this and or say this: tactile fremitus not felt anteriorly as the patient vocalized 99. Anterior lung sounds are clear to auscultation. No adventitious sounds heard. Another assessment we do is chest expansion. So we are assessing for chest expansion, symmetric or asymmetric. It should be symmetrical, but this provides clues regarding the presence of any chest wall pathology, lung volume loss, or any obstruction. So how are you going to assess chest expansion? There's a slide over here on the right. It shows you where you're going to place your thumbs. So while your patient is in maximal expiratory, place your palms over the patient's posterolateral ribs with your thumbs touching in the midline, as you can see on the right. And you're going to have the patient take a deep breath in and a deep breath out. And your thumbs should move equally bilaterally up when the patient is taking a breath in, and they move together as the patient exhales. So make sure you do chest expansion, and then how you would document and or say this is chest expansion is equal bilaterally anteriorly. Next, you're going to assess the AP diameter. So the AP to the lateral diameter of the chest should be a 1:2 ratio. If your patient has a flat chest, which is the expected finding, the anterior-posterior AP to transverse diameter is 1:2. Now, what you're trying to differentiate is a flat chest versus a barrel chest. So a barrel chest is where the AP diameter to the transverse diameter ratio is 1:1. A barrel chest is seen in physiological states such as infancy and old age, and in pathological states such as COPD, because that patient has emphysema. Now, there's a condition called pectus carinidum, or people refer to it as pigeon chest. It is the forward protrusion of the sternum and adjacent costal cartilage. And this is seen in children respiratory diseases such as asthma, rickets, Marfan syndrome. So you expect your patient to have an AP diameter of 1:2 ratio. If there's a barrel chest, here I gave you a slide on the right. You can see how the barrel chest sticks out wide. So the ratio between one shoulder to the other shoulder should be 1, and then the ratio from the posterior to the anterior chest should be 2, so that the anterior chest to the posterior chest should be twice as big as the the size between the right and left shoulders. But here in the barrel chest, you can see it's more like a 1-to-1 because the barrel chest is sticking out further. We have completed the anterior lung assessment. We have looked at the skin. The skin is warm and dry. The color is appropriate for their ethnicity. We have assessed tactile fremitus. We have assessed chest expansion. And we have auscultated the anterior and lateral lung fields, because on the front, when you're assessing the lung sounds on the front, remember you're going to go under the breast to the sides, which are the lateral aspects of the lung fields. So now we're moving on to the back. So you're going to look at the patient's back. Again, we're going to assess skin, warm and dry, color is appropriate for ethnicity, no lesions, masses, bumps, open areas noted. And we're going to do the tactile fremitus on the back. So I gave you a visual here on the right-hand side, and it tells you more about the tactile fremitus, but we're going to do the same thing that we did on the front. So we're going to start on the top of the shoulders with our palms, and we're going to basically go down the spine. You're going to have one hand on each side of the spine, and then make sure you go around to the lateral sides again. So remember, put your palms on the patients on top of the shoulders, starting way up there. Say every time you feel my hands move, just please say 99, 99, 99, 99. And you will document this as tactile fremitus equal bilaterally upon palpation. Next, we are going to assess for CVA tenderness. So there's a slide here I want you to look at, because what we're going to do, we're going to do this over both kidneys, and we're going to place one hand flat over the kidney, and you're going to make a fist with the other hand, and you're going to gently hit your hand. And you're assessing for any pain or tenderness with this, because this could indicate an infection going on or some other issues that we need to alert the physician about. So put your hand over the kidney, flat, take your other hand, hit your hand, and then we're going to do this on the right and left sides for your right and left kidney. And if they don't have any pain or tenderness, how you're going to document and or say this is no pain or tenderness noted on CVA percussion. So this is a percussion technique. Now, like I said, we have to do everything the same for the anterior chest and the posterior chest. So we need to do chest expansion on the posterior chest. And I have a slide here for you to see where you should place your thumbs. So you need to place your thumbs underneath the rib cage, and your thumbs should be close to one another, as you can see here in the slide. You're going to have the patient take a deep breath in and out. Your thumbs should move outward symmetrically upon inspiration, and then the thumb should move together inwardly during expiration. So how would you say and or document this? Posterior chest expansion equal bilaterally. Now we can move on to listening to the posterior lung sounds. Here's a diagram to the right that shows you in which manner you should systematically listen to your patient's lungs. You're going to assess right to left in a systematic fashion. You are assessing for any wheezing, crackles, or rhonchi. Again, this might take a little bit because you want your patient to inhale and exhale slowly. We don't want to make our patients hyperventilate, so allow them to take their time as you listen. If you don't hear any adventitious sounds and it all looks good, how you will document and or say this is posterior lung sounds clear in all fields, no adventitious sounds heard. Now we're moving down the body to the abdomen. So our patient is lying down at this point in a supine position. Of course, you want to ask about any pain in their belly, when was their last bowel movement, any pain with urination, any problems starting a stream, any discharge, when their last menstrual period was. If they have a Foley, you're going to look at the Foley, look at the urinary drainage bag, see how many cc's are in there. So first we're just going to look at the belly. You need to talk about the contour. So the abdomen should be flat, but the contours that we can describe include flat, rounded, or protuberant. You might see some pulsations in the aortic artery, which is normal. You want to make sure that the umbilicus is midline. You're going to be looking for any wounds, making sure that the abdomen is symmetric, any lesions, rashes, open areas. See if they have a PEG tube. If they have an ostomy, make sure to look at that stoma. Make sure it's pink. And look at the stool, if there's any stool in the bag. Then, we always, in the abdomen, we always listen before we touch the belly. So remember this, it's very important. Always listen first, and then we will palpate. So we're going to listen to the bowel sounds in all 4 quadrants. So that's right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. And when you put the diaphragm of the stethoscope on each quadrant, you should hear continuous gurgling. You should hear noise. If you do not hear any noise, you need to listen to that quadrant for 5 minutes. 5 minutes, it's a long time to see if you hear any gurgling or any movement, because that's when you can say the patient has absent bowel sounds in right lower quadrant or whichever quadrant you're in. So hopefully you put the diaphragm on the quadrants, you hear gurgling, they sound good, and you would record that as normoactive bowel sounds. Now, if you put the stethoscope on the belly and you're listening for 5 minutes and you hear a couple of gurgles here or there, that would be hypoactive bowel sounds. And then if you put the diaphragm on the belly and it's like a continuous gurgling and it's like the patient might be complaining of pain, maybe the patient's having diarrhea, these are active, hyperactive bowel sounds. And remember, you can only say absent bowel sounds when you've listened for 5 minutes and have heard nothing. So then we need to use our bell because we are going to listen to the vascular sounds. So we're going to switch our stethoscope over and we're going to use the stethoscope to listen for bruits at the aortic artery. So find the umbilicus and go about 1 inch above the umbilicus and place the bell of your stethoscope there. And again, we're listening for bruits. So we're listening for any swishing sounds. You shouldn't hear much. Then we're going to go down to the renal artery. So you're going to move your stethoscope to the right and like an inch down. And you're going to listen to the left and right renal arteries. Again, you're listening for bruits. If that's good, you're going to move down probably 1 to 2 inches. Again, right and left. We're going to listen to the iliac artery. We're listening for bruits. And then we're going to move our stethoscope down close to the pubic area. And we're going to be listening for the femoral artery. Again, any bruits noted. Then after we've listened, then we can do some palpation on the belly. So we want to palpate each quadrant individually, and you're palpating for lumps, masses, and we start light first. So you can do a light palpation in all 4 quadrants. Just make sure that the pain doesn't increase or there's a sudden sharp pain. And then we can go back and do a deeper palpation, 4 to 5 centimeters, and we're feeling for masses, lumps, and making sure that the belly is non-distended and that doesn't elicit pain. It's not comfortable, but it shouldn't elicit painful stimuli. The patient shouldn't scream out loud in pain. They might say that doesn't feel comfortable. This doesn't feel comfortable when anybody pushes on your belly, but what you're really trying to feel for are any masses or lumps that you need to report to the provider as soon as possible. What are you going to document and or say? You're going to say bowel sounds active in all 4 quadrants, no bruits auscultated in aortic, renal, iliac, or femoral arteries, abdomen is flat, non-distended, no masses palpated. Next, we are moving on to assess the upper extremities. So we want to look at both upper extremities together at the same time. You're going to be looking for any redness, swelling. Look at the central line or IV if they have one. You want to palpate pulses, brachial and radial. You do this at the same time because you want to compare left to right. So you take your 2 fingers, you find the brachial pulse, 3 plus equal bilaterally, and then you find the radial pulse, both sides at the same time. Radial pulse, 3 plus equal bilaterally. If they have an AV fistula, you want to feel for the thrill because there should be a thrill with an AV fistula. You want to check the capillary refill. Make sure that it is less than 3 seconds. So what you're going to do is both hands at the same time. You're going to push on the nail bed of a finger on each finger at the same time. Push down on it, release it, and the blood return should come back within 3 seconds. So capillary refill less than 3 seconds. And then we need to look at the range of motion of the fingers, hands, and the arm. But before we ask our patients to move, we need to look at the joints and feel the joints. So starting from the shoulder joint to the elbow to the wrist to the fingers, you want to make sure that you don't see any bulging, redness, pain, lack of mobility. So you're just feeling for any of that. You're going to look at the joints in the fingers, feel every finger, make sure that knuckles are not inflamed or red. And then we're going to test our muscle strength. We're going to place our 2 fingers out in front of the patient with your right and left hand, and you're going to ask the patient to squeeze your fingers because you want equal strength bilaterally. We're going to have them hold out their arms in front of their body, close their eyes just for a few seconds, and you're looking for any drifting upward. So, how can we assess these joints? So for the shoulder, we can ask the patient to lift his arm up and then bring it back down. So flexion, extension, and then we can ask the patient to bring his arm out to the side away from him, abduction, and then bring his arm in front of him, crossing the midline of the body, adduction. So this should be freely moving. You're going to have him do it once without you touching the joint, and then you're going to have him do it again while you're actually touching the joint because you want to be feeling for any crepitus or nodules and free range of motion. Next, for the elbow, we're going to look at the elbow, any redness, swelling. You're going to have the patient raise his forearm up to his shoulder, flexion, extension. Then you're going to have him do that again while you're feeling the elbow and you're feeling for any crepitus or any deformities. Then we're going to move to the wrist. we're going to have the patient lift his wrist up and then point his fingers down. So wrist flexion and extension. He's going to do it once on his own, and then you're going to be feeling that joint as he does it for any crepitus. Then we're going to look at the fingers. We're going to ask him to spread out his fingers as far as possible, and then squeeze, make a fist, and then spread the fingers again. This is kind of hard to feel while the patient's doing this, so just make sure that you feel each knuckle. You can do this while you're doing your capillary refill. Just make sure that there's no redness or any deformities noted. And then you can have the patients again spread their fingers, bring their fingers close together, finger adduction, and then we're going to ask them to spread their fingers out, finger abduction. So again, with the hands, just make sure you're feeling the knuckles, feeling all around the joints of the hand, and then making sure that the patient can abduct and adduct their fingers. So how will you say and or document your findings on the upper extremities? You're going to say upper body extremities. Skin is warm and dry, no masses, no lesions. Patient denies pain in joints. Brachial and radial pulses are 3+, equal bilaterally. Capillary refill less than 3 seconds bilaterally. Patient is able to flex, extend, abduct, and adduct shoulders, elbows, wrists, and fingers equal bilaterally. Before we move on to the lower extremity assessment, I just want you to make sure that you understand what a normal Babinski response is and an abnormal Babinski. So you would take your hammer, your reflex hammer, and you're going to use the sharp side, as you can see in the illustration above, and you're going to go to the outer part of the foot. So you're going to start at the heel, moving that sharp part of the reflex hammer up the outer part of the foot and around to the big toe. So a normal or a negative Babinski reflex is when the toes point down. An abnormal or a positive Babinski reflex is when you take that sharp end of your reflex hammer, you go on the outside of the foot from the heel all the way around to the big toe, and if the toes fan out or fan up, this is a positive Babinski reflex. So you want your patient's toes to go down, not up. So here we go to the lower extremity assessment. And I gave you a visual here on the right so you can kind of see what the exercises we have our patients do to check their range of motion. And remember, we always need to have them do it once on their own. And then we provide resistance to make sure that their muscle strength is equal bilaterally and that there's no crepitus or pain noted or lumps or nodules. So the first thing we always do is inspect the color of the legs, warm and dry, appropriate for ethnicity. You want to look at the even hair growth. So is there one leg completely filled with leg hair and then one leg is completely bald? So we need to make sure that you have even hair growth, equally bilaterally. We want to assess for any abnormal swelling, pain, redness in the joints. You want to look at the bottoms of the feet for wounds or open areas, and you're going to look at the toenails for toenail health. Of course, we need to palpate our pulses at the same time on each side. So we're going to palpate the popliteal, the posterior tibialis, and the dorsalis pedis. That's the one on the top of the foot. So as you're feeling, you want to ensure that you're feeling the pulses equally on both sides and that they have equal strength. Then, since you're down looking at the toes, you can check capillary refills on the toes. You're going to do each side together. So you're going to squeeze the two big toes, put some pressure on it, release the pressure, and the blood flow should return within 3 seconds. Then on their shins, you can assess for edema. So you're going to take 2 fingers on both sides and push over the tibia and look for any indentation. We don't want there to be any. We don't want our patients to have edema. Then you're going to feel all joints for any deformity, pain, and we're going to have them do their range of motion exercises. So for the hip, we're going to have them bring their leg up, flexion, and then bring it back down, extension. So you're going to do one leg and then the other leg. Bring the leg up for flexion and extension. Now we're going to have them do this again, but we're going to add some resistance to make sure that they can still move their extremities, moving that joint against resistance. So you can place your hands on top of their thigh, ask them to bring their leg up against your resistance, and then once the leg is up, you're going to switch your hands and put them underneath the thigh on the bottom side of the leg and ask them to push down against resistance. And of course, we're going to do this on both sides because we're assessing if it's symmetrical. Then we are going to have the patient do range of motion on his knees. So we're going to have the patient bend his knee toward his chest and bring it back down. And then on the other side, bring his knee toward his chest and then bring it back down. Then you're going to do it again with resistance. So you're going to be placing your 2 hands above the knee and ask the patient to flex his knee. And then once the knee is flexed, you're going to switch your hands to the underside of the leg and have him extend, straighten his leg, and against resistance. Again, we're going to do this on both sides. Then we are going to assess the abduction and adduction of the hips. So you're going to ask your patient to take one leg and move it out away from him, and then bring it back in to the center of the body. And then, of course, the other side, move your leg out, away, abduction. Think abduction, something's being taken away. So abduction is moving a body part away from the body. And then ask the patient to bring his leg back to midline of his body, and that's adduction. Think about adding something to the body. Then we're going to do this again with resistance. So you are going to stand next to the patient. If he's doing the right leg, you're going to stand next to the right leg. You're going to put your hands on the upper thigh on the outside and ask him to abduct. And then put your hands to the inside of the thigh and ask him to adduct. We're going to do this for both sides because we want to make sure that it's equal bilaterally. Then we can move down to the ankles. And so what you're going to do is ask your patient to point his toes toward his nose and then point his toes down to the ground. He's going to do this at the same time with both ankles. And then you're going to do it one more time while you place your hands on top of his feet and ask him to point his toes toward his nose, and then put your hands on the bottom of his feet and ask him to point his toes down. And hopefully all of those exercises were felt equal bilaterally with resistance, and the patient didn't complain of any pain or numbness or any discomfort during those exercises. And then we talked about the Babinski reflex in the previous slide. So you're going to check the Babinski reflex with your reflex hammer. You're going to use the silver part, the end of the silver part. You're going to go from the outside, you're going to do it on the outside of the foot, on both feet. So you're going to start from the heel, go out toward the outside of the foot, around under the toes, and end at the big toe. Do this for both feet, and your Babinski reflex should be negative. So their toes point down, they do not point up. So how are we going to document and or say this out loud about the lower extremities? The lower extremities assessed, equal hair distribution bilaterally, no redness, lesions, open wounds, skin is warm and dry. Popliteal, posterior tibialis, dorsalis pedis, 3+ equal bilaterally. Capillary refill less than 3 seconds and equal bilaterally. Patient was able to perform range of motion independently with and without resistance, equally bilaterally. Babinski reflex negative. We are getting close to the end of our head to toe assessment. So now we're going to ask the patient to stand up. We're going to look at their back. So have them face away from you. We're going to inspect the skin for any moles, wounds, lesions. Look at their coccyx to make sure they don't have any skin breakdown. You're going to feel with your fingers down the spinal process for straightness. Then you're going to ask the patient to lean forward and touch his toes, or try to touch his toes, if this is appropriate for that patient. And again, you're going to feel down the spine to assess for straightness. You're just going to walk your fingers down the spine, make sure it's a straight line. Then you're going to have the patient stand back up, and we're going to assess for the Romberg test. So you're going to have the patient close his eyes, keep their hands at their side, and stand there. You need to stand there with one arm in front of the patient and one arm behind the patient. You can look at the slide, the picture to the left, and you're going to ask them to stand there with their eyes closed, and you're making sure that they're not losing their balance or they're not swaying back and forth. So how you would document and or say this: posterior skin warm and dry, no lesions, redness, masses, lumps. Spinal processes are straight and in both standing and forward-leaning position, negative Romberg. The final part of the head-to-toe assessment is assessing walking and balance. So the patient's already standing up because we just assessed his back. So we're going to ask the patient to walk 5 steps away from us, walking normally. Then you're going to have the patient turn around and walk back toward you on their heels. Then have the patient turn around from you and walk on their toes. And then finally, you're going to ask the patient to move one heel up the shin of the leg that's standing on the ground. And then you're going to repeat the opposite side. And how you would document and or say this: patient has a steady and coordinated gait, able to walk on toes, heels, and move heel up each shin without loss of balance or coordination. And ta-da! You're done with your head to toe assessment.